Patients will tell me that it was probably easier than what they were expecting. So I think a lot of patients come in expecting that they're going to have drains, that they're going to have pain for multiple weeks, that they're going to be in bed. And, after our consultations, we want our patients up and walking around day one. I think most patients are surprised that they didn't require that much narcotic medication, maybe a day or two, or just to help them sleep. And, that they were, it was a much quicker recovery than they expected. And I think most patients are kind of surprised that they didn't require drains. So we use a lot of drains for a lot of different procedures. In breast reductions, I am a believer that it's not indicated. In our literature, there's a few indications for leaving a drain, and that's if the patient is morbidly obese. Oftentimes, they're probably not a great surgical candidate to begin with, or they are, need to lose weight before surgery for perioperative reasons, or if the specimens are going to be over a kilogram per breast. And even at that I think is a case by case. And so you're creating a dead space that you're rotating tissue into to create a smaller breast mound or get the breast tissue up higher onto the chest wall. And so fluid can accumulate in that dead space. And so we worry about seromas and hematomas. The drains will identify those, but they don't necessarily prevent them. So we worry most about a hematoma. If something were to start bleeding, it's pretty obvious if something does bleed, the breast swells. And so regardless if you have a drain or not, you would have to go back and stop that bleeding. So I don't necessarily think drains are warranted with breast reductions, but certainly with other procedures. Looking at my numbers over the last few years, I've done well over 100 breast reductions, and I've had probably 2 hematomas. So 1, 2% maybe. And that's the one complication that would require us to go back to the operating room. It's pretty obvious. So it does depend if it's like venous or arterial. Venous, lower pressures. And so sometimes those will stop on their own and they can be monitored or just aspirated in clinic once they liquefy. Certainly an arterial hematoma, or if something were to start bleeding, the pressure is much greater. And so it will fill that dead space pretty significantly or even dissect planes. So the breast becomes like 2-3 times the size of the other breast, significant bruising and pain because of that pressure. And so it is pretty obvious if there's an arterial bleed and a need to go back to the operating room. There can be multiple reasons. So with certainly like bleeding diatheses, if patients have any bleeding disorders. But with anesthesia, blood pressures are dropped. And so as patients recover, blood pressures come up. With increased blood pressure, it can cause something to start bleeding. It is also why we tell our patients to just take it easy for a few weeks, because those first 2 weeks, there can always be a risk for delayed hematoma or something to start bleeding. So certainly things like trauma, even no exercise. So we don't want our patients to do anything that gets their heart rate or blood pressure up, as that could also start something to bleed. And then just the liquefaction process. So, we use electrocautery, but we're clotting basically or embolizing vessels as we dissect. And the body naturally liquefies clot after a few weeks. And so sometimes that can just spark something to start bleeding.